Well, good morning, everybody that's in person and remotely. Welcome to Cardiology Grand Rounds. Today is a special Grand Rounds. We have a new category of distinguished lecturers, our trailblazers, and Corey fits one of them, and I'll try to explain why. So Corey is joining us from Washington University in St. Louis. He's associate professor in cardiovascular division and section of heart failure and transplant. He is the co-director of the Center for Cardiovascular Research. And Corey has done his previous training starting at University of Rochester with his bachelor's, and then has been at Washington University ever since with part of their MD PhD program, internal medicine residency, cardiology fellowship, advanced heart failure, and then he spent some time in the lab of Dr. Mann, who's one of the experts in cardiovascular biology. He joined the faculty in 2014 as an instructor, promoted, he was appointed to assistant professor in 2016, associate professor in 2019, and it's really his laboratory has made seminal discoveries in area of macrophage biology, inflammation, and he'll show you some of the of his work. He's been quite productive in terms of publications, with more than 85 publications in circulation research, Nature, JCI, and he has received funding from the NIH. He has R35, multiple R01s, and funding from AHA and the Leduc Foundation. His work has been recognized by being inducted into the ASCI, and he was at the Northwestern Young Investigator competition, where Daniel Yang and I had met him several years ago. And last year, he received the ISHR Mid-Career Investigator Award, which makes me feel old because we thought we're still young, but I guess now we're mid-career now. So Corey has been visiting us for the past couple of days to get an outstanding lecture yesterday, and we're looking forward to his grand rounds today.
Thank you for the kind introduction. We are not old. It's hard to say middle-aged. So, anyway, thank you so much. It's been a great visit, and it's a pleasure to have an opportunity to give this fantastic grand rounds today as a speaker and visitor. So I spoke yesterday a little bit about a population of reparative immune cells within the heart. And today I'm going to switch topics and talk about inflammation, how we can think clinically about targeting inflammation in heart failure and myocarditis. This works. Okay, we're good. So I have no important disclosures. I received some consulting from the Tronic Flame Implicit Conixa and some industry sponsored research agreements, but nothing relevant to this particular talk. And that has been verified. Okay, so the outline of what I'm going to talk about today is talk about opportunities to target inflammation in heart failure and really focus on innate immunity. I'm going to speak a little bit about implementing precision medicine paradigms in cardiovascular research and thinking about how that can be used for translation. And then talk about a population of inflammatory monocytes and macrophages that are marked by the expression of CCR2 and their role in heart failure pathogenesis, and discuss them as a new target for therapeutic development. And then end with how we're thinking about translating our findings and other findings in our field, and then the indications that might be most appropriate for immunomodulatory therapy and clinical development pathways to consider. All right, so I wanted to start with just a schematic that I think summarizes how many of us think about heart failure. This is shamelessly adapted and stolen from Doug Mann, as everyone at WashU does. So this is a nice schematic. I think it summarizes decades of work. But I think most people believe that heart failure really begins with an index event. And that index event acts as an injury to the heart. It can easy to conceptualize as a myocardial infarction, but can be a lot of different things. Environmental exposure, exposure to chemotherapy, drugs that you should not be taking, meth in my area, in many areas, or the genetic expression of a previously silent trait. And that index event acts as an injury. And as many of us have seen, when the heart's injured, rarely, but occasionally, people will spontaneously recover and do well. But the majority of patients undergo progressive remodeling. And so at the macro standpoint, remodeling is nicely represented as dilation of the ventricle and eccentric hypertrophy. And at the microvascular level, fibrosis, hypertrophy, and in some cases, capillary rarefaction. Pretty much all the therapies that we have for heart failure target this remodeling process. So angiotensin II inhibitors, beta blockers, aldosterone antagonists, probably neprilysin inhibitors, cardiac resynchronization therapy. I think that no one really knows how SGLT2 inhibitors work right now, but it could be around remodeling. But that's really the target of the majority of our therapies. And remodeling therapy, as we know, is pretty good. So there's about 20 to 30% of patients who undergo reverse remodeling, less than 5%, but a significant subset will completely recover LV systolic function. Many patients will achieve disease stabilization, but there are a population of patients that those that are in the advanced heart failure space see routinely that continues to grow over time that are in the need of advanced therapies like transplant and LVAD. So while our therapies are good, there's certainly room for improvement. There's room for looking for other mechanisms that are important for the remodeling process. We know very little about what are the mechanisms that truly promote recovery and reverse remodeling. And we do very little about the index event that initially causes heart failure. And in some cases, that index event is inflammation. Inflammation has also been implicated in the remodeling process as well. And so that represents an interesting area that has been explored previously. So what is the role for the idea or evidence that inflammation may be contributing to heart failure pathogenesis? And so I think there's two nice lines of evidence that really can stand out. One is just basic histology. If you look at across the different pathologies of heart failure, whether it's an acute myocardial infarction, ischemic cardiomyopathy, this is within the infarct or within the border zone, diseases that are increasing our recognition like sarcoidosis and other forms of myocarditis, arrhythmogenic cardiomyopathy, which I'll talk about towards the end of the talk, and in even other non-ischemic cardiomyopathies, there are immune cells all over the myocardium. And as you can see from these images, those immune cells look different across these pathologies and likely play different roles. The other line of evidence is from biomarker studies that have been performed for the past several decades. And so it's well established in the literature that serum levels of numerous inflammatory mediators, things like TNF and IL-1 and IL-6, and the list goes on, are increased in patients post-MI, and they're increased in patients with heart failure, and they're associated with clinical outcomes. So this is, I think, a nice example of that. This is TNF concentration in the blood on the y-axis. On the x-axis is NYHA functional status. And as you can see, as people have worsening severity of heart failure, the amount of the TNF in their blood is higher. And the amount of TNF is also prognostically relevant. Higher the level is, the more likely you are to have a poor outcome. And so these really fundamental studies and important observations led to a number of clinical trials that were performed in the 90s and 2000s, and some even recently. And these therapies really looked at kind of these trials looked at broad anti-inflammatory therapies, things like steroids, cyclosporin, TNF antagonists, more recently IL-6 antagonists. And they've unfortunately produced either disappointing or modest results. Disappointing in the context of TNF, and then modest when we look at things like steroids and IL-6 antagonists, which had very small but measurable improvements. And I think one of the main issues in this area is that the cellular mediators that promote inflammation in the heart remain really unknown. We don't know the sources of these individual inflammatory mediators. What are the cells making them? And we don't really know which one of these are actually causally linked to the disease pathogenesis. And as a result, I believe there's an unmet clinical opportunity to target inflammation in the pathogenesis and progression of heart failure. We just need to know what to target and who to target, what patients would be good candidates for those therapies. And so I think this field kind of went quiet for a while. And then more recently, with the publication of the Canto Study and further analysis of the Canto Study, I think there was some glimmer of hope. So as everyone remembers, the Canto Study was a secondary prevention study looking at IL-1 beta neutralizing antibody, and it was largely focused on recurrent ischemic events, but was reanalyzed looking at outcomes that are a little bit more heart failure related, things like heart failure hospitalizations, non-fatal MI, stroke, unstable angina, all-cause mortality. And when you analyze this population on the broader level, there's a dose-dependent reduction in these adverse events that is in response to the IL-1 beta neutralizing antibody. But what I think is probably more important is if you stratify these patients by who responded or may have responded to the I1 beta therapy, you see a very big difference in outcomes. And so this is a reanalysis looking at CRP. So every patient had to have an elevated CRP to enroll, and then patients were stratified by whether their CRP went down in response to canakinumab, the IL-1 beta neutralizing antibody. As you can see by looking at the number of events, the number of patients whose CRPs achieved less than 2 is less than half of the population. I think that's the first important point. And those who did achieve that actually had major reductions in adverse events across these endpoints, which tells us that anti-inflammatory immunomodulatory therapy can be effective, but it's only effective in some patients. And these patients are heterogeneous. There's more than one inflammatory mediator that's driving their disease. And I think that really speaks to precision medicine therapies of trying to identify the right therapy for the right patient. And if you hit the target in that patient, you can actually improve outcomes. So how can we do that? So I'm a basic and translational scientist. So when I think about this, I think about going back to the lab and trying to understand the mechanisms that drive inflammation and heart failure, which ones are present and which ones are targetable. But I think there's a problem with the way we traditionally think about basic science and how it applies to this issue. And so when many of us do basic science work, we do discovery in either disease models. Many times that's little critters like mice or zebrafish or cell culture, whether it's standard cell lines or more recently human pluripotent stem cells, which are much better systems. And then from these models, we try to select targets or mechanisms of action that may be related to disease. And our selection actually is highly biased. It's biased by our past experience. It's biased by what's in the literature, which sometimes can be an echo chamber. And it's most importantly, biased by the model we use or restrained by the model you use. So if you use a model that only exemplifies a portion of the disease, you're not going to identify targets that are not well represented by the model. And then in the end, people hope, right, that their therapy is going to be relevant to humans. And I don't want to totally put this down. It's worked. It's worked in the sense of Gleevec for CML. It's worked in terms of tafamidis for TTR amyloid. This has worked for some immune checkpoint inhibitors in the oncology space, but there's many examples of this not working. And so I believe that there may be other approaches that can really help us. And I think one of those approaches is doing discovery in the disease that matters, and that's in the human disease and human tissue. So about 2019, my group within WashU set out on an initiative to really create infrastructure to do true discovery in human samples. And so this was a great time to do it because technologies to truly understand the composition of cells, what the cells are making, how cells are organized in human tissue in an easy way, were just evolving. It's a really exciting time to do science. And so these are some of the technologies that are available, technologies where you can take fresh or even frozen tissue that's been in the freezer for 20 years and do single cell sequencing to look at the RNA and chromatin features. And it allows you to identify what cells are actually in your tissue and figure out what they're expressing that could be important for disease. This now even works on paraffin tissue from blocks that have been in pathology for years. We now have technologies to map these cells in space to understand how they're organized and how they create niches that can be enriched for certain inflammatory mediators, which may be targets for therapy. We can do biomarker studies. Instead of looking at 5, 10, or 20 biomarkers, we can look at thousands or tens of thousands at the same time from a few hundred microliters of plasma or serum. Human genetics continues to be powerful and being refined every day and linked to these other metrics. And probably the biggest advance that's occurred over the past 5 years is actually being able to identify therapeutics in the laboratory space by using chemistries that are really compatible with what we do in the basic science laboratory and be able to identify novel compounds. And I'll highlight that at the end of my talk. And so we thought we'd want to take these new concepts and methodologies and try to apply it to cardiovascular disease. And we came up with this initiative called the Cardiovascular Precision Research Initiative. It nicely is this, the acronym is CPRI, which is probably my biggest contribution to it. And the real goal of it is to try to define disease at the patient level, to identify causative mechanisms, and to develop precision therapies. And the way we do this to define disease at the patient level is we use a lot of the technologies I discussed in the prior slide to categorize disease, to discover new cell types, new inflammatory mediators, new signaling mediators that might be driving disease. We then take those hypotheses and test them in the most appropriate animal model, where that model recapitulates that particular mechanism, and ask whether there's a causal link between that particular pathway and the disease phenotype. And then you develop diagnostic platforms that allow us to select patients where that mechanism is active, and create therapeutics, whether they're biologics, meaning antibody-based, or small molecules through DNA-encoded chemistry that are matched to those particular mechanisms. And that's the overall vision. And I'm going to show you an example or two so I'm going to show a few examples how we've used this technology to try to identify new targets for therapy for inflammatory forms of heart disease. All right, so the first thing that we set out to do is to try to understand what are all the immune cells that exist within the failing heart. And to approach this, we went on kind of a mission to do a number of sequencing projects so we could categorize the cellular landscape of both the failing and healthy heart. And we've done this across non-disease donor hearts, individuals that had non-ischemic cardiomyopathy, which is shown here. We've also done this with patients with ischemic cardiomyopathy, acute myocardial infarction, and a lot of other inflammatory forms of heart failure. This is an example of looking at donor versus dilated cardiomyopathy, and this is the immune landscape. The most important thing I'm going to show you is that the number one immune cell that exists within the heart are monocytes and macrophages, which are shown, put my pointer up, which are shown in this green color here. And there's almost as many monocytes and macrophages in the heart as pericytes, and about half as many as fibroblasts. And the number two population is T cells. There's a few B cells and mast cells that are also within the epicardial space. There's so many macrophages actually within the heart that if you take any random field and you do immunostaining with an antibody against CD68, which identifies monocytes and macrophages, shown in green here, you can find many of which in any field. So they're very prevalent. Okay, and so work in our lab has shown that these macrophages can be divided into two classes or two lineages. The macrophages that we all learn about come from monocytes from the bone marrow, and then they're recruited to tissue at times of disease or injury through a monocyte intermediate. And this monocyte intermediate is activated and recruited through the heart through activation of a receptor called CCR2 or CC chemokine receptor 2. And that will become important later in the talk. This macrophage population is actually the minor populations in the resting heart. The majority of macrophages come from an embryonic source, and they seed the heart early during development. They live there independent of monocytes, and they can be identified because they do not express the chemokine receptor CCR2. This is what an average flow cytometry plot of what macrophages in the heart look like. And I'm only showing you this to give you an idea of numbers. So the CCR2 positive macrophages that come from the bone marrow are the minor population. They're shown on the right side of the graph. And then the CCR2 negative macrophages that come from the embryo are shown on the left side of the graph. And they have very different origins and functions. So the CCR2 negative macrophages are long-lived. They're maintained independent of monocyte input, and they play key roles in homeostasis and tissue repair. So if you had an anti-inflammatory therapy that got rid of them, that could affect repair, has been worried about in a lot of immunomodulatory studies. On the other hand, the CCR2 positive macrophages are maintained by monocyte recruitment. They accumulate in the injured and diseased heart. They express inflammatory and oxidative mediators at robust levels, and they're both associated with and causally linked to heart failure pathogenesis. So you'd want a therapy that targets one, but not the other, and that's been one of the challenges in the field. I'm not going to belabor this, but I just wanted to highlight some of the very interesting things that this reparative macrophage population does. It's actually important for regenerating the heart in appropriate models. It's important for developing vasculature, both in the embryo and growing collateral vasculature. They play roles in modulating metabolism, promoting tissue repair and recovery, facilitating conduction, preventing inflammation. They're actually important for suppressing rejection in a transplant situation. And they're important for adaptive remodeling of the heart in response to physiologic stresses. So that's a population that we don't want to target if you want to try to quench inflammation. On the contrary, these CCR2 positive macrophages are very different. So they're shown in green here. They live within the myocardium. They extend processes within the interstitial space. Sometimes they actually wrap around and inside blood vessels. This population of CCR2 positive macrophages are inflammatory. They live within the myocardium. They try to sense injury. And so the interesting thing about them is they get activated in response to myocardial damage or injury. And they sense basically death of myocytes. And they play key roles in initiating the inflammatory response and maintaining that. And they do that by releasing a number of inflammatory mediators, many of which you can recognize here because they're markers for heart failure. And they do this through a classic signaling system regulated by MyD88 and NF-kappa B. And so through these mechanisms, they govern the recruitment of neutrophils and monocytes into the heart and contribute to damaging inflammation. And their abundance is associated with adverse remodeling in heart failure patients. And if you remove them in animals, which I'll show you in a second, you can dramatically improve outcomes. They don't live alone within the myocardium. So this is a sequencing analysis. We're able to map cells in space. And so what I want to highlight is they actually live within a niche that contains T cells and activated fibroblasts. And that niche is shown here in this population 0. And if you look at the pathways and genes that are active within this niche that contains the CCR2 positive macrophages, there's a lot of signaling for JAK-STAT mediators, which are a lot of cytokines, and NF-kappa B, which is important for macrophage activation. So they really they kind of live in this neighborhood that's promoting inflammation. Okay, so we've spent a lot of time in the laboratory trying to understand how they get activated. If one understood how they get activated, that could be a therapeutic target. And so we understand that they get activated now through toll-like receptor and IL-1 receptors. The toll-like receptors sense mediators that are released from dying cells, things like DNA or lipids. And then IL-1 receptor obviously senses IL-1. And the nice thing is that each of these pathways converge on common signaling system that's regulated by this adaptor molecule called MyD88, and most importantly by this kinase complex called IRAC. And these IRACs are can be targeted by small molecules. And I'll show you one that we've made briefly. And through these mechanisms, mediate the generation of a lot of different inflammatory mediators. So hitting this target is nice because it hits upstream. We've also been interested in understanding which of the mediators that these cells make contribute to disease. And so this is a list of a lot of the different ones that we've studied in the laboratory. We've identified pathologic roles for IL-1 beta and IL-6. We recently identified one for this chemokine that no one's ever heard of called CCL17, which actually prevents the recruitment of regulatory T cells that suppress inflammation. So by blocking it, you can actually resolve inflammation quicker. And then osteopontin, which is important for T cell and fibroblast activation within that niche. And we're very interested in developing biologic agents that act as neutralizing antibodies, not for one of these targets, but multiple, and kind of think of them as traps or sinks. Okay. To give you an idea just how big of an impact that these cells and mediators have on cardiac function and remodeling, this is one mouse experiment we did. This is an MI model, mirrors what patients kind of experience. They, in this model, the mice get 90 minutes of ischemia followed by reperfusion using a closed chest system, and then they're echoed 4 weeks later. And so this is an example of one of the echoes where you can see that there's a nice infarct, there's a bit of remodeling and reduced LV systolic function compared to a wild type animal. And then if you either remove CCR2 positive macrophages, prevent their activation or generation of some mediators like IL-1 beta and CCL17, you can really improve outcomes. You can notice the infarct is quite a bit smaller when it moves. The function is a bit better, and the LV volumes are quite a bit less. So you can have a pretty dramatic effect on physiology and remodeling by any of those particular interventions. And each of these interventions leads to reduced leukocyte infiltration, reduced generation of inflammatory mediators, less infarct expansion, less fibrosis and remodeling, and improved systolic function. And the most interesting thing from a biologic standpoint is that if you remove this population of macrophages or prevent their activation, you actually break apart this niche. This red niche that we think drives disease gets broken up and the cells will redistribute in the myocardium in different areas. So not only affecting what the cells are and what they make, but their localization within tissue, which is important for setting up inflammation. All right. The other areas that my laboratory is interested in exploring from a therapeutic standpoint is this concept of monocyte fate specification. So I get asked the question a lot, can you make a monocyte become a reparative or regenerative type cell? And the answer to that actually is yes. So when monocytes enter the myocardial tissue, either in mice or humans, they can differentiate into 7 or 8 different macrophage populations, some of which are harmful, things like TREM2 macrophages or arginase 1 positive macrophages, and some that actually are beneficial, such as resident macrophages or resident-like, and ones that express type 1 interferon. And so if you could steer a monocyte to become a less inflammatory cell, that would be a very natural therapy. And it's very natural because you have millions of monocytes entering the heart every hour after an infarct or in the setting of an acute tissue injury. And that's one of the areas that we're actively working on and thinking about what are the intrinsic and extrinsic cues that a monocyte experiences as it chooses to differentiate into an inflammatory or reparative cell. The other, I think, interesting thing that we've begun doing from a therapeutic standpoint is thinking a lot about how you can come up with targets in the lab, but how can you actually translate this? And you can't completely rely on pharma because our interests are not always matched. And I think one of the great challenges in basic science has been, how can you make drugs? How can you make therapeutics? And so for years, therapeutic discovery was driven by doing plate-based assays, screening for compounds by activity, and screening libraries that may contain 10 or 100,000 compounds that pharma's already done with and is given to us. But we really want to screen in new spaces. We want to screen larger libraries and do this differently. And so this was a technology, called DNAEncoded Chemistry, was developed by a few laboratories across the world. One is Marty Matzuk's laboratory at Baylor. He actually trained at WashU, and I overlapped with him when I was a graduate student. And so he developed this chemical library that's made by combinatorial chemistry. So you build one block on another. Each compound is a unique DNA barcode, so it has its own index. And these libraries, instead of containing 10 or 100,000 compounds, contain billions of compounds. This particular library we use contains 3.3 billion compounds. And it's a very simple assay. You take your protein of interest. For us, it's the IRAC complex. You tag it with an epitope so you can pull it down, and you mix it with this library. And you mix and wash and spin it down in a little tube. And then you sequence the compounds that stuck to your particular protein of interest. And based on those DNA barcodes, you can identify the needle in the haystack, essentially, that binds tightly to your target, and see a lot of unique or a lot of related chemical structures that give you an idea about structure-activity relationship. And so in doing this, you can identify compounds that bind tightly to your protein, and then you want to do a secondary screen for compounds that may modulate protein activity. And so we did this with the IRAC complex, and we identified a family of compounds that works at under 10 nanomolar in terms of inhibiting kinase activity on the first screen. And we're currently developing those as a therapeutic to prevent CCR2 positive macrophage activation. This work was done in 6 months, which shows the type of power that the system has and can be done in any average basic science laboratory. This compound, which we've named 1878, inhibits IL-1 beta production in macrophages nicely in vitro. But probably the most important experiment that we've done to date was looking either myocardial infarction or sepsis models, like giving LPS, either in the airway or IV. And this compound actually very potently reduces the production of IL-1 beta. So this is IL-1 beta in the serum. These are normal animals treated with vehicle. Animals treated with inhibitor, they did fine, no tox issues. Animals that treated with LPS make tons of IL-1 beta, and that's dramatically suppressed by giving this small molecule in vivo. So one of the other challenges I think that pharma is facing is, how do you deliver the right drug to the right cell? So there's lots of drugs out there that have on-target but undesirable effects. A good example is IL-6 inhibitors, which inhibit a lot of inflammation, but also inhibit mucosal repair in the intestine and the mouth. And so you would want to inhibit immune cell activation without permitting mucosal repair. And so there's a challenge of getting the right drug right to the right cell. And one of the solutions to that is using biologics that are conjugated to drugs, so so-called antibody drug conjugates or nanobody drug conjugates. And so we set out to make one to try to deliver our IRAK inhibitor to the cell types of interest. And so antibody-based therapeutics are great. They can be used to neutralize signaling. They can be used to deplete cells, but we're really interested in using them for targeted drug delivery. And so we've made a nanobody recently against CCR2 using a camelid library. It works really well. It binds to CCR2 positive monocytes selectively. It works in mouse and human. And then most recently, we've made a linker such that we can conjugate our IRAK inhibitor, and that linker is only broken in the endosomes of macrophages, which are very acidic. So we can try to deliver our drug to the cell type of interest. And that's how we would envision moving forward with this sort of pathway. So another challenge I think that's out there is how do we deliver the right therapy to the right patient? If you have a great immunomodulator out there, whether it's a small molecule, an antibody drug conjugate, how do you just select the right people to give it to? And so this was a question that Doug Mann, and I don't know if anyone here knows Phil Needleman, that's really pushed forward. Phil is a benefactor of WashU, but he knows a little something. He makes Celebrex and Sutent and a few other drugs. So he's always telling us exactly how to do things. And so he's actually been instrumental in this project. And so if we think about how to implement therapy, like our pool of patients would be patients, potentially those who had MI, those who have heart failure or chronic myocarditis, people with VT or VF, I don't want to exclude them because you certainly can have inflammation as a key component of arrhythmogenesis. So that's our possible pool of patients. And so you want to have a way to take that patient population and narrow it down to those that have inflammation. So we currently do that, I think, with FDG PET, somewhat okay, and cardiac MRI, but we can do it a lot better. And biomarkers with CRP, I think, kind of just, as you see, it's really just the icing on the cake. It's not all mechanisms of inflammation, and only works for some patients. So we really need a way to say that the target that you want to hit is in this patient population or not, to match the therapy with the patient. And the approach I'm going to talk to you about is molecular imaging to do that. And then you want to be able to deliver your drug, right, to that patient, and then you hit your target. So we felt that these CCR2 positive monocytes and macrophages early on was going to be a good target for therapy. And so we set out to make an imaging probe so that's has the ability to see these cells non-invasively in people. So we don't always have to do heart biopsies. Certainly explanting the heart is not going to be a good approach to treatment. So you have to have a way to see the cells. And so we worked with Youngjun Liu, who's a radiochemist at WashU, and Rob Groppler, who's a really great human imager. And we made a peptide probe that binds an allosteric position into the CCR2 receptor. So it's shown in green here. It binds on the side of the molecule, but it doesn't interfere with ligand binding or signaling. This is a sequence of the peptide if anyone's interested. And then we conjugate it to DOTA, which is a moiety that chelates radioactive metals so we can make an imaging probe. In our case, copper or gallium. The peptide's pretty good. It has an IC50 of about 60 nanomolar in THP1 cells and is specific. And we've developed this in mice nicely, but I wanted to show you the human data, which hopefully will be published sometime soon. And so we set out to see if this probe works in human patients, starting with ST elevation MI. We did that because if we didn't see a signal here, we didn't think that the probe would work very well. And it's nice because MI patients are in the hospital, and in our hospital, we watch them for 72 hours, so they're pretty bored for 3 days. And so this is an opportunity to image them. So the protocol we use is we enrolled healthy subjects and patients who had an ST elevation MI that were revascularized. Patients underwent a technetium SPECT CT just to identify viable areas of myocardium and to control for blood flow. And then we did a CCR2 PET image later in the day. So as you would expect, a healthy subject has nice uptake in the SPECT CT and very little uptake in the heart of our CCR2 radiotracer. This is a patient who had an MI 4 days ago, obviously an anterior MI. You can see the green arrow shows the deficit in the infarct. And in the orange/red arrow here, we have nice CCR2 uptake of our tracer within the infarct. The interesting surprise that we saw from these studies is that we saw persistent inflammation in a number of patients. So we saw persistent CCR2 uptake 3 and 4 weeks post-infarction. And in some patients that persistent LV dysfunction, we would see it months after their myocardial infarction, which means that the therapeutic window for implementing immunomodulators may be greater than we would suspect. If you ask any company that's interested in going into the space, they want to give the drug like in the ambulance. But this type of approach could suggest that there may be a patient population that is most likely to benefit that could be given in a more delayed and safe fashion. This is the quantitation of that data just to show really how digital it is. So these are the control here is the healthy subjects. This is the infarct of a STEMI patient. And you can see that there's absolutely no overlap of data points. And we're a little bit underpowered in this initial study, but there's probably a small elevation outside the infarct within the border zone as well. We did not see any uptake in other muscle tissue, such as skeletal muscle, or any increased uptake in blood. And then this is the uptake as a function of time following MI. You can see it's persistent over longer periods of time. And we've now imaged about 20 patients, and these data continue to hold up. And so we're very interested.
One patient longitudinally?
Yeah, these are individual patients. For this study, we used our copper tracer. It has a half-life of 36 hours and more area under the curve of radiation. So we've gotten through the FDA or gallium tracer, which has a 6-hour half-life. And then they will allow us to do serial imaging on patients. We were unfortunately above the radiation mark to do serial imaging. So we're setting out to do a study where we're imaging on a every other week basis post-STEMI using the gallium probe. I would have loved to do that one first. So we're very interested to use this to define the natural history of the accumulation of these CCR2 positive cells in various forms of heart failure. We've done this now in sarcoidosis and arrhythmogenic cardiomyopathy, and it works brilliantly. We're really interested in evaluating patient heterogeneity and figuring out for MI, which of the factors are prognostically important? Is the amount of uptake? Is it the persistence of uptake or the location of uptake? And that could help guide us to think about what patients we should treat. And our ultimate goal is to use this as a tool to effectively implement immunomodulatory therapies. So what I like to end with is talking about what are patients that are most likely to benefit? How should we translate this into the clinical domain? So there's the first time that we thought of it, I'm sure half the people in the room are thinking the same thing, that myocardial infarction would be a great way to implement immunomodulatory therapies. But if there's any interventionalists in the room or people in the CCU that work, they can say many patients do just fine and don't really need anything beyond revascularization. And I think that's right. There's a set of patients that has, stealing Paul Ritker's words, that has residual risk after reperfusion therapy and remodeling. And that population gets smaller over time as we get patients to the cath lab sooner and our technologies for caring for the patients get better. And so that is a logical indication, but that may be a really hard sell up front. And so thinking about other indications, this paper came out in 2020, and it's like the hit of the biotech world. And so this is the story of rilonacept for recurrent pericarditis. So rilonacept is an IL-1 trap. It was made by Regeneron, and it was tested in about every indication possible before they gave up. And then the smaller company called Canixa decided to license it and wanted to pick an indication that had really no background therapies to see if it would work. And they picked the indication of chronic recurrent pericarditis, which I don't know about you, I've seen like 3 cases in my life. And they did a clinical trial where it included a gigantic number of 61 patients, 31 in the placebo group and 30 in the rilonacept group. And by definition, this disease has no treatment, right? Because it's chronic and recurrent. And they used a endpoint of freedom from recurrence. So by definition, if you got the placebo drug, you're essentially going to have a recurrence. And so individuals in the placebo arm had a 90% recurrence rate over a 42-week period. And there's no background therapy. And so patients that got rilonacept that had chronic recurrent pericarditis had a 10% recurrence rate. And then they got FDA approval for this drug. And it's kind of like the home run of biotech. And so we wanted to think about, was there a similar indication where we can implement immunomodulatory therapies for inflammatory heart disease? Is there a disease that's not common, easy to identify, malignant, and then not have very good background therapy, so you can really only improve outcomes? And the disease we decided to focus on is arrhythmogenic cardiomyopathy, or ARVC. So many are probably familiar. It's a disease that's associated with cardiomyocyte loss, fibrosis, adipocyte dysplasia when it's in the right ventricle, and inflammation. This is your standard cardiac MRI where you see late gadolinium enhancement pretty much everywhere. So it's not just affecting the RV, but many times affects the LV. And when you look at these pathologic lesions, you see areas where there's all sorts of different cells replacing myocardial tissue. And I'll show you what they are in a second. The nice part about this disease is it's genetic with high penetrance. More than 75% of patients have mutations in desmosome genes like desmogliin, plakophilin, desmoplakin, adherence junction genes like alpha-cadhenin, and then some Z-disc components, mainly I think FLNC and SCN5A have the phenotypes that most resemble many of these ARVC or ACM patients. So fairly easy to identify these individuals when they're out there. And they have terrible prognosis. So their freedom from life-threatening arrhythmogenic events is really terrible. And we don't have much to offer them beyond transplantation, palliative antiarrhythmics, and defibrillators to protect them from life-threatening arrhythmias. So for us, this kind of fit the mold. And so we set out with human tissues to try to understand what the cell types existed within this disease. We're able to work across a few institutions to get a collection of about 10 tissues. And we did a bunch of sequencing. I'm not going to bore you with all those details, but these lesions contain basically large amounts of macrophages and monocytes. And they're actually all the CCR2 positive cells. So this is an H&E image of a donor control. This is an ACM lesion. And it looks just like a bunch of fibrosis, right, if you look at it. But if you start staining it, you knew what's in there and stain for it, you can see that this lesion is chock full of monocytes and macrophages. And so we were lucky to collaborate with Jeff Safetz, who is actually my medical school professor and head of my thesis committee before he moved to Beth Israel. And he's been there for many years. He's been very interested in arrhythmogenic cardiomyopathy. And in collaboration with Steve Chelko at Hopkins, had made a mouse model where he essentially made a truncation in desmogliin 2. And so this mouse develops all the same features that you would see in patients. There's a lot of fibrosis, for instance. I'll show you that there's lower ejection fraction, and there's a lot of ventricular atrophy. And so we worked with him to ask whether CCR2 positive cells, these CCR2 positive monocytes and macrophages, were causally linked to disease. So we essentially crossed these mice with CCR2 knockouts, so they wouldn't have these cells, and all the fibrosis actually went away. The mice have a lot less ventricular premature beats. So these green are the controls. In red are the disease model. You can see the red arrowheads are all the ectopic beats. And then when we knock out CCR2, the number of ectopic beats is dramatically reduced, and that's quantified here. We see less inflammation, so we can see reductions in the myocardial levels of IL-6, periostin, and CCL2, and then we can improve cardiac function by looking at ejection fraction in these mice. So that causally links this population of cells with disease and arrhythmogenic cardiomyopathy. And I should mention we've been able to replicate these findings with IL-1 beta antibodies and other proprietary antibodies that prevent the activation of CCR2 positive macrophages. And we're currently actually designing a first-in-person clinical study in this area. The type of study that we imagine, the endpoint we're interested in actually is looking at ventricular ectopy, runs of NSVT, and treated episodes of VT that can actually be remotely monitored if patients have defibrillators, which would be a cost-effective clinical trial design. So our lab is interested in using these paradigms across other diseases as well. Some of the other diseases that we're exploring are recurrent ischemic events. We now know that recurrent MI is different in terms of its immunologic features than a first MI. We're very engaged with looking at ICI and myocarditis and identifying novel therapies that can prevent myocarditis that occurs as a result of immune checkpoint inhibitors without inhibiting the anti-cancer effect of those molecules. I mentioned ARVC. We're very invested in transplant rejection, whether it's looking at antibody rejection or transplant vasculopathy, and also sarcoidosis, where we've been recently able to identify what the giant cell is and what the other macrophages are within that granuloma that drive the generation of granulomas that we can now recapitulate in mice. So these are all really exciting stories that started with studying human tissue. And I think it speaks to the power of using that approach. So the take-home points that I really want to emphasize is that inflammation can be targeted in the heart using precision medicine approaches, and that immune cell specificity is an important feature. You have to know what the cells are and what they're making to match the right treatment to the right patient. That among these populations, that the CCR2 positive population of macrophages targeting its specification, activation, and effector cytokine signaling mechanisms could represent new targets for immunomodulatory therapies. Molecular imaging, while not at great scale, can be a way to initially begin to identify patients that are best served by particular treatments. And that immunomodulatory therapies can be developed in the academic environment. That's the biggest message that we've received over the past few years, that we're not completely dependent on pharma and industry, and we can do these things within our own laboratories, which I think makes the work we do even more rewarding. And then to begin, we're very interested in using arrhythmogenic cardiomyopathy as a model to a model indication to advance immunomodulatories therapies against our macrophages of interest. So I have a lot of people to thank. My laboratory is listed on the left here. This type of science is done as a team and involves many groups across my institution, as well as outside. This is our imaging group here, our transplantation group, our precision medicine group, and many of our collaborators across the country. And the ones that are highlighted in the red contribute to these specific projects. None of this can be done without our funding. And none of this also can be done without being in a great setting. So this is a picture of our Center for Cardiovascular Research at WashU. We have a really lively group of people, a lot of young trainees at the graduate, postdoc, fellow, and junior faculty levels. And if you ever have an opportunity to come out, we'd certainly welcome you. So thank you so much. I'd be happy to take any questions.
Fantastic. I guess for the those in person, there's a microphone there if you wanted to use. David.
Yeah, that was a really impressive talk, Corey. I have a couple of questions. I'm sure you've encountered both of them before. One is specific and the other more general. So you talked about precision medicine and you showed the data where the I guess the response in the canakinumab trial depended on the lowering of the CRP. In your imaging of the patient of the post-infarct patients with CCR2, though, they all seem to be pretty closely clustered. So there didn't seem to be a lot of heterogeneity there and an opportunity for precision medicine. So that's one observation. The other is that the Achilles heel of immunomodulatory therapy obviously is susceptibility to infection. And so how do you, CCR is there for a purpose, and part of it is responding to infection. How are you going to, do you anticipate dealing with that side effect of immunomodulatory therapy?
Yeah, thanks for those questions. So the first one's a little easier to get at. So the imaging that we did for the STEMI patients, we really enriched our clinical, we enriched in STEMI and in acute for the most part. And we had some subacute patients as we went out, which is very different than the Canto study, which is secondary prevention, people that had infarcts months and years ago. We have now done a larger group of patients. And when we look longer out at 100 days or 200 days, we start seeing patients that don't have inflammation. So we think there is some heterogeneity at later time points. In our sarcoid imaging, there's actually a tremendous amount of heterogeneity. Patients that light up like Christmas tree and patients that you see no signal at all. So I think the potential for that is there. We just have to look for it in a systematic way and tie it to the correct outcome so we know what it means. Your question about the Achilles heels of anti-inflammatory therapy and immunomodulators, that's always going to exist and always going to be a balance. And I think by selecting patients most likely to benefit from therapy, you're going to sway the risk-benefit ratio in your favor. We do this every day in the transplant field. And I think it's good to hear that comment because my risk tolerance is a little different with transplantation. I'm used to having patients on all sorts of immunosuppression and biologics. And I think the risk of infection is a little bit, I think it's a little over embellished. It certainly does happen, but I don't think it happens super commonly. So as an example, we also can use human genetics. So patients that are deleted in MYD88 or IRAC, really have very small increases in infection. So I think it's there, but I think it'll be best managed by managing risk-benefit ratios. So if we don't want to expose people that are not going to benefit at all, I think that would be a negative effect.
Rob?
Hi, Corey. Great talk. I want to follow up David's the imaging you were doing was very cool. So I just have a couple of questions. Are you seeing uptake in the bone marrow? Have you looked at, and then the second part of it is, it seems, your initial slide was how macrophages are involved in multiple pathologies. We don't have a great non-invasive sort of imaging for inflammation in the heart. And I'm just wondering how this compares to FDG, for instance. Is this just more specific, higher sensitivity? Is it something that we could use more generally in instances where we think there's an inflammatory component?
Yeah, thank you. We're really excited about the imaging too. So we think it's more specific than FDG. You don't have to do any dietary or suppression protocol. So in Missouri, that's a real pain in the behind. You tell people to fast, they have 1 piece of bacon and 1 glass of sweet tea, and they fasted that morning. And obviously their PET CT does not look like you'd want it to. So there's practical issues with PET CT, with FDG, that the CCR2 probe doesn't encounter, but is more specific in our opinion. I think bigger studies where we directly compare it to FDG will be important. We're doing that in sarcoid, which I think will be the best area for that. In MI, the FDG uptake with the infarct those studies have not been wonderful and very informative. So we think it could be more sensitive than FDG.
And one other question, and I'll turn it over to you. I think there are a number of folks here and obviously around the that are doing small molecule screens as an attempt to try and find new therapeutic targets. And most of the focus is on its sensitivity in terms of inhibiting the enzyme. How do you go about, without having things that leap into humans, figuring out off-target effects?
Yeah, that's an important challenge. So our approach has been using knockouts. So for instance, in mice, our compound targets the IRAK complex. And we can see a therapeutic effect in mice in response to LPS or MI or something. Then we use IRAK knockouts and see if that therapeutic effect is gone. That gives us at least on-target specificity. Off-target specificity is much harder problem to deal with. Is there a kinase that inhibits that is not in one of the kinome screens that could be a fallibility? I think that's very difficult to approach. I think tox studies are pretty good. I brought that up to Phil Needleman because I had the same sort of question coming from an academic standpoint. And as a former head of pharma, he said, who cares? And that was hard to hear. He's like, if it hits the target and it doesn't have toxicity, it should work. And I'm not sure that that's the approach we want to take, but that's the feeling of that's the idea of the general field. One of the things I really like about biologics and antibodies is that problem doesn't exist to the same degree, right? So antibodies tend to be more specific than small molecules. You can screen for, off-target binders of antibodies, and I feel like it's a much more comfortable approach. And so beyond this IRAK inhibitor and small molecule, we're spending a lot of time in the antibody space for those reasons.
Chuck?
That's a really nice body of work, first off, so congratulations on that. One of the big plot twists that was fun to see was the way that you could target the CCR2 positive macrophages in arrhythmogenic cardiomyopathy, which I had always just considered, yes, there's a little bit of inflammation there, it's just they're cleaning up the cardiomyocyte death, something like that, but I didn't really have that as part of the disease pathogenesis. So help me think about, how do you view the role of the macrophage now in promoting arrhythmias in this disease?
Yeah, I think so we believe that the way the macrophages are potentially promoting arrhythmias in this disease is the following kind of mechanism. So we think myocytes are dying in arrhythmogenic cardiomyopathy due to structural issues and lack of desmosomes and adherens junctions and other filaments. The myocyte death is activating through DAMPs these CCR2 positive macrophages, which are forming this inflammatory fibrotic niche that contains a lot of activated fibroblasts, the ones that are studied in a number of labs across the country, periostin positive, FAP positive fibroblasts that may be arrhythmogenic. And we think that that niche of cells is creating electrical dispersion that could be driving arrhythmogenesis, driving fibrosis, and a collateral hit to the myocardium. And so we're not eliminating the niche and electrical dispersion. Yeah, we don't know yet. We don't know yet. I think that clearly it's replacing myocardium, right? So you could get re-entry around that. I'm not an electrophysiologist, so I'm not going to dive into that any deeper. You certainly could be affecting the myocardium as well. We're onboarding systems to try to understand that in a more detailed way, using optical mapping. The thing that we're most interested in doing is in humans. And so we're currently pairing our CCR2 PET imaging with arrhythmogenic cardiomyopathy to ECG imaging. So we can see surface potentials in patients and co-register areas of inflammation with areas of electrical conduction, slowing, dispersion, et cetera, to get some ideas. That's definitely more your area than mine, so I'd be happy to hear your comments.
I would never have imagined it, so it's your area.
I don't know. We work on one of the cells in that area. It's a lot of people's area, but I think it's something we hope to learn more about in the future.
Corey, just to follow up on Chuck's question. So if you look at like MRIs and look at like fibrosis or things like that, is there overlap? And I guess one could argue that can you go after the fibrosis rather than the inflammation to be more specific?
Maybe. We think that in this model, these inflammatory cells are causally linked to the fibrosis. So we think that the macrophages are at least initially upstream of the activated fibroblasts and fibrotic lesions.
And do you think the fibrosis is reversible, I guess?
It could be. We're exploring that. So we have a number of anti-fibrotic, bispecific antibodies, different depleter lines that we're breeding into this model to test that question. Because it may be one of these codependent feedback loops, and it doesn't matter which arm you target. And so that's an open area, and it'll be interesting to see.
Perfect. I think we can end because Corey needs to go to the airport to get to a cheerleading competition.
For my daughter.
Yes, not for him. Yes. Thank you, Corey. That was amazing.